Well, hello everyone. This is Joe Minardi. I'm coming to you live from the WVU Emergency Medicine Recording Studios. And today our topic is point of care ultrasound in trauma patients. Specifically, we're going to talk about the FAST exam and how that can help you in trauma patients. We're going to go a little beyond that and talk in detail about some of the evidence. We're going to talk about some of the pearls, the pitfalls, but then we're also going to talk about some of the decision making surrounding trauma patients and the use of ultrasound in the FAST exam. And specifically, I want to talk about how even in the modern era of CT scanners right next to the emergency department that only take about 15 or 20 minutes, how the FAST exam is still going to be a value-added tool and give you value-added information in trauma patients, no matter what your practice setting. So if you're at the level 1 trauma center, tertiary referral center where you're accepting trauma patients and your department's full of trauma, stroke, and all kinds of different patients that are being referred, or whether you're working in a critical access hospital where the timeliness of your decisions can make a big difference in the outcomes of these patients, the FAST exam and ultrasound in trauma can help you stratify these patients, make decisions on who gets what resources and when, and really can impact the care of these patients. So with that, let's dive right in. Here are the objectives for our CME purposes. Not going to read those to you. And as always, I like to keep things focused on a few key points. And so if you remember anything from our discussion here, there are really only a few key points. The FAST exam, and again, we're going to spend a lot of time talking about the FAST exam. FAST exam can really only make 4 diagnoses for you. It's either going to be a yes or no on these diagnoses. And those diagnoses are hemopericardium, pneumothorax, hemothorax, or hemoperitoneum. That's it. We'll talk a little bit about some of the other findings that you may be able to identify, but for the strict purposes of what we're confidently able to rule in or rule out with pretty good certainty, it's hemopericardium, pneumothorax, hemothorax, and hemoperitoneum. Everything else that you may see, get clues to, is added bonus and has to be considered within the context of the clinical scenario and recognizing the limitations of ultrasound in these settings. And then our decision making is pretty straightforward. If the patient is unstable and we see any of these findings, then we may need to act on those and either direct or plan or do certain interventions to help these problems. If the patient is stable, we get valuable added information about which patients need what resources in what kind of timeline. And that can help us whether we're in a busy trauma center with a dozen other critically ill patients surrounding us, or whether we're in a critical access hospital and we need to make decisions quickly about, can this patient stay here? Does our surgeon need to come in from home? Or should we go ahead and deploy our resources to get this patient transferred to a trauma center expeditiously? And as you all know, if you guys have been with me for any kind of time with any of these CME web courses, you know I like to start off with a few cases. So here's our first case. This is a case of a patient with motor vehicle crash. They come in with some abdominal pain. Vital signs look pretty okay. Here's a little sampling of some of the findings. I'm not going to quiz you on what they are now. We'll get into those a little bit later. Our second case, this is a 36-year-old male, fell a few feet off of a ladder, has some left chest pain, but again, pretty good looking vital signs. So here's one little component, a little sampling of the findings on this FAST exam. And this is our third case. This is a young female who fell. She's a little intoxicated, so maybe the history and physical aren't as reliable as we would like. But again, we see some pretty stable vital signs. And this is an older female, our fourth case, who comes in after a motor vehicle crash. A little bit hypotensive, heart rate's okay. Breath sounds are diminished on the left. So think about what that means and what you might be doing in that situation. Here's just a little bit of extra information from that case. And again, we'll dive into those findings a little bit later. And our fifth case, 32-year-old male, presents after blunt chest trauma. This particular case was, if I recall, mauled by a bull, not made up, but presenting awake and alert with maybe some iffy vital signs. And the sixth case, we've got a 38-year-old male after an ATV crash. If any of you are from around here, you know these are the state vehicle of West Virginia is the ATV or the four-wheeler. It is legally mandated that you start learning to drive these when you're 2 years old. You're specifically not allowed to wear a helmet. This particular patient, short of breath, hypoxic, had some diminished breath sounds on the right side. And so here's some of the potential findings that maybe we would see. And so with those cases in mind, we'll kind of think about those. We'll revisit those after we've looked at some of the findings. We're going to talk about point of care ultrasound and trauma, the FAST, and then going beyond the FAST, a little bit into decision-making pearls and pitfalls. So as usual, going to remind us, keep ourselves focused on the key points. Remember, there's only 4 diagnoses we're going to make with the FAST exam or trauma and ultrasound. And those 4 diagnoses are hemopericardium, pneumothorax, hemothorax, and hemoperitoneum. And the decisions we're going to make are going to be immediate interventions, whether we need to do them or not in the unstable patients. And then in the stable patients, we hopefully have some additional valuable information that's otherwise not really accessible to us at the bedside immediately. We can then act on and then allocate our resources appropriately, especially if we're in a busy department or if we're in a smaller critical access department. We have to make quick decisions about where the patient's going to go, what are they going to do, and what kind of timeline do we need to be on. Here's my pretty simplified, straightforward decision-making algorithm. So we have our trauma patient, and mostly we're talking about blunt trauma, but I will touch a little bit on penetrating trauma because there is additionally a role for the FAST exam in penetrating trauma. So in these patients with trauma to the chest or thorax, we'll perform our FAST exam, and if those patients are not stable, so that's the first thing, then that probably means we should direct an intervention. Again, we're always going to incorporate the whole clinical scenario and decide, but maybe that means the patient needs a chest tube, maybe they need a thoracotomy, and again, that decision is going to be made depending on where you are and what kind of resources you have. Maybe they need a laparotomy, and again, is that going to happen where you are locally, or is that something you need to expedite that patient toward laparotomy? If the patient has a positive FAST exam, but they're stable, then you can probably go ahead and do further imaging, which is often going to be a CT scan. However, that patient who is stable has findings that threatens their stability. So they need to move up the line as far as getting to CT scan. They need to be assured that they have that second IV in case they decompensate. Maybe the blood, your emergency blood, needs to be traveling with that patient or needs to be nearby. The nurses who are busy with other patients, maybe those resources need to be pulled to go with that patient to CT scan. So even in the stable patient, the positive FAST exam can play into your decision making. That's one of the key points that I hope to get across. So that's down this side of the tree if the FAST exam is positive. Now, if it's negative and they're not stable, then you've got to debate whether you're going to do other interventions. Are you going to do a DPL? Are you going to do a CT scan? Are you going to do further imaging? Are you going to resuscitate and continue the FAST? So we can, if they're unstable and their FAST is negative, then we have to think about other things. And at the very least, we should resuscitate and repeat the FAST after, a significant amount of blood resuscitation or something else is done. And then the patient who has a negative FAST and they are stable, so this is the other place where we can throw in and we can kind of add some of our clinical decision-making skills. Now, there's not a perfectly well-defined clinical decision rule around this, but using the FAST exam, using this with our clinical information, we can decide, be a little more selective with our CT scans, because we all know we do too many CT scans, especially in trauma. But maybe if they're stable, the FAST exam is negative, we can decide, are they high risk or low risk? And if they're high risk, then, we do the CT scan. They're high risk because they still have significant abdominal pain, maybe they've got an acidosis, they've got bruising to their abdomen or their chest or something like that. However, if they're not high risk, then maybe we can follow them clinically. We can do serial exams and labs, repeat the FAST in 20 minutes and at 6 hours or something like that. Not saying, again, not going to have the singular decision for every single patient you have, but incorporating this into the stable patient can help you be a little more nuanced in your decision making. So let's just talk a little bit about why we do the FAST exams. So when we think about the patient with us at the bedside, we have just a few tools at our disposal. History, physical exam, and maybe you can do a DPL. But the FAST exam, we have it at the bedside. It's quick. We can repeat it as needed. There's no radiation, no contrast. It's very cheap, and it's more accurate than anything else we may have to us available at the bedside for some of these findings. As I alluded to, we all know that we do too many CT scans, especially in trauma patients. Trauma patients are some of the most radiated patients that we care for. So any effort we can make to decrease some of that radiation exposure is worthwhile. Even if we only cut it 10 or 20%, that's a significant load of radiation in the population of patients that we see. So who should get a FAST exam? Anybody with trauma to the kind of chest, trunk, abdomen, back area should have a FAST exam. It adds information to the history and physical, stuff that we can't get by other means, and I just consider it part of the primary survey in the trauma patient. Now again, if they have isolated penetrating trauma, their elbow, they don't need a FAST exam. But anybody with trauma, chest, trunk, thorax, abdomen, back, they should all get a FAST exam. Now, the unstable patient, we talked about this a little bit already. This is where it has its most critical role. This can help us guide some of our immediate decision making. So do they need a chest tube? Do they need pericardiocentesis? Now, again, this depends on where you are and what your resources are versus thoracotomy. And that's a debate we won't get into at the moment. You know what resources you have on hand where you work, and that's how you're going to decide on that. Whether they need laparotomy. And again, maybe that's something you can do where you are, or maybe that's something you need to expedite moving that patient toward. In the stable patient, this is where things are a little bit different. We can make important diagnoses rapidly at the bedside, sooner than we could with any other modality. We can establish a baseline so that if something changes with a patient, we can repeat it later to see if the findings have changed. And we can use this to incorporate being more selective with our CT scans. And overall, lowering costs, increasing yield, and lowering the overall exposure of patients to ionizing radiation. Now, as always, we have to talk about the limitations, right? And you hear this all the time when you think about ultrasound in general. The ultrasound is operator dependent. It's patient dependent, right? So patients may be obese. They may have dirt and glass all over their body, which makes doing the FAST exam difficult. I'm just going to cross those off. Those are excuses. Everything we do in medicine is operator dependent, and most everything we do is patient dependent as well. If the patient gives you a bad history, that's going to make you're going to be more prone to mistakes. If there's lots of reasons patients are difficult to examine and different procedures are difficult on patients. These are not reasons not to take care of patients. And these are not reasons not to use tools that we have at our disposal to help us take care of patients. But other things, as far as imaging itself, if you see a pneumothorax, with the views that we talk about, we're not able to really quantify that. You could quantify it with some more extensive views, but that's not usually of interest in the resus bay, so we're not going to talk about that. So generally, you can't quantify an pneumothorax. You can't tell how big it is, and we'll talk about how to deal with that. We can't generally image the retroperitoneum very well, so a patient may have retroperitoneal bleeding that is unidentified with a FAST exam, so you just have to know that. You have to know the limitations when you go in. And parenchymal injuries that are contained, like a renal hematoma or a splenic hematoma, may not cause hemoperitoneum. So those injuries may exist, and we don't recognize those with the FAST exam and with ultrasound. And that just goes back to all the things we do in medicine, knowing the limitations of what we're doing and understanding the questions that it can answer versus the questions that it can't answer.